Hi everyone, I'm Devi Soman, a postdoctoral fellow at Clemson University. Thank you all for joining us today to hear about my dissertation study exploring the role of freestanding birth center physical environments in supporting culturally sensitive care experiences and maternal health outcomes for historically underrepresented communities. The study was supported by the American Association of Birth Centers Foundation through the AABC Research Grant and the Center for Health Design through the 2023 Joseph G. Sprague New Investigator Award. So, why look at maternal care in the US? The maternal death rate in the US increased by 89% between 2018 and 2021, with close to 800 pregnancy related deaths in 2022. In 2022, birthing persons often reported having poor maternal care experiences due to mistreatment and discrimination. Studies show that poor experiences and outcomes are more common among birthing persons from racially and ethnically diverse, historically underrepresented communities, or HUCs. Studies also showed that childbirth and beginning of life are culturally significant events for birthing persons from HUCs. Having a culturally sensitive, open minded, patient focused approach can lead to culturally sensitive care or care that is responsive to the attitudes and beliefs and circumstances of birthing persons from HUCs, which in turn improves patient provider trust, treatment adherence, overall maternal care experiences and outcomes, reducing the prevailing maternal health disparities. We also know that the physical environment of maternal care settings influences care experiences and outcomes, and culture and lived experiences shape our spatial preferences and experiences within. However, we do not know how the physical environment supports culturally sensitive maternal care. So, what is culturally sensitive care? Culturally sensitive care has two components. On the one side, providers' cultural competence or their ability to provide care that is responsive to the birthing person's cultural needs, and cultural sensitivity or the birthing person's perception of whether the care was aligned to their values and beliefs. Together, culturally sensitive care can improve responsiveness to beliefs and circumstances, patient provider relationship, feeling of community support, care participation and adherence, and the likelihood of physiological birth, improving their overall outcomes. Studies show that birthing persons from HUCs have experienced culturally sensitive care within the midwifery model focused on sensitivity, safety, and appropriateness. Among other settings, midwifery care is provided at community based freestanding birth centers or FSBCs. FSBCs run by midwives provide an alternative for BPs with low to moderate risk pregnancies to experience childbirth in a tranquil, familiar, and low tech settings. The number of FSBCs have grown in the United States over the last few years, yet little is known about their physical environment and how they support culturally sensitive care. To understand this more, we build the study on three theoretical models from health sciences, midwifery, and environment and behavior. The first model, the patient centered culturally sensitive healthcare model, highlights the physical environment as a characteristic of the healthcare facility that influences the patient's perception of providers' cultural sensitivity. So it adopts a more contextual approach towards the physical environment. The second model, the expanded birth territory model, shows the physical environment on a binding scale, which can either induce feelings of safety and comfort on the one side or vulnerability and discomfort on the other side. So this adopts a more spatial approach towards the built environment. The third one, the theory of supportive design, highlights the features of the physical environment that can provide a sense of autonomy, positive distraction, and social support to reduce stress, adopting a more elemental approach towards the built environment. We integrated these three theoretical models into a study conceptual framework that shows the physical environment as an organizational factor, along with organizational and provider characteristics. These organizational factors and the birthing person's individual factors together influence culturally sensitive maternal care in various aspects of the birthing person's care experiences. So, through this study, we wanted to know how the physical environment of FSBC supports culturally sensitive care experiences and outcomes of birthing persons from HUCs. The study has four parts. In the first part, we conducted a literature review to understand how the physical environment of maternal care settings supports the culturally sensitive maternal care needs and outcomes for birthing persons from racially and ethnically diverse groups in the United States. In the second part, we conducted surveys with birthing persons from historically underrepresented communities and their support persons who've visited a freestanding birth center to see if there is a relationship between their perceptions of cultural sensitivity and the FSBC physical environment they received care in. In the third part, we conducted interviews with birthing persons, support persons, and freestanding birth center staff to understand how the FSBC physical environment supports culturally sensitive maternal care experiences. And in the fourth part, we conducted case studies at 4 freestanding birth centers led by midwives from HUCs to see how their physical environment helps them provide culturally sensitive care to birthing persons from HUCs. The findings from these 4 parts helped us address our main objective: to develop evidence-based design guidelines for maternal care spaces that support culturally sensitive care for historically underrepresented communities. For today's presentation, we'll focus on part 3 and part 4, that's the interviews and the case studies. So as I mentioned earlier, with the interviews, we tried to dig a little deeper to understand how the freestanding birth center physical environments supported the culturally sensitive maternal care experiences for HUCs through interviews with birthing persons from HUCs, their support persons, and freestanding birth center staff. We spoke about the surveys in the previous part. We primarily recruited birthing persons from HUCs who had visited a freestanding birth center for childbirth and their support persons for the survey. To do so, we requested freestanding birth center staff to share the study information with their communities through emails, text messages, and social media posts. That helped us recruit some of the community members for the survey. At the end of the survey, we asked participants whether they would like to participate in a follow-up interview. Simultaneously, we recruited birthing staff members at 4 freestanding birth centers serving HUCs in the US through snowballing. The staff members filled out a short survey where they could express their willingness to participate in a follow-up interview. The interviews were scheduled through an online scheduling platform. They were conducted virtually and recorded after receiving consent. The questions were mostly semi-structured in nature and captured the participants' maternal care experiences at FSBCs, perceptions of the FSBC physical environment, childbirth-related beliefs and practices, and the FSBC physical environments that help them accommodate these, supporting their culturally sensitive maternal care experiences. Participants received an incentive after completing the interview. We conducted 28 interviews in all, and their audio transcripts were cleaned and de-identified for further. We used a thematic, deductive, inductive approach for our analysis. The study framework and research questions informed the code categories and overall structures, whereas the actual codes within these categories were inductively developed from the qualitative data. After creating a codebook, 3 coders underwent 3 rounds of pilot coding to familiarize themselves with the codebook, refine the codes and code definitions, and improve our IC, which was close to 1 towards the end of it. After that, 2 coders coded all transcripts to get an IC of close to 0.99. We resolved coding disagreements over 4 sessions of consensus coding. The codes related to the physical environment and care experience were analyzed and synthesized to understand how the physical environment might support these themes. So a little bit about the demographics of our participants. Of the 28 participants, 12 were birthing persons, 5 were support persons, and 11 were FSBC staff members. Most of our participants identified as non-Hispanic or non-Latinx, Black or African Americans. Most of us birthing persons and support persons were between 26 and 30 years old. 11 of them had the childbirth experience in 2023. 8 of them had an annual income between $25,000 to $49,000, and most of them had some college education but no degree. On the other hand, our birthing staff members, most of them were between the age of 36 to 50 years old, and they served multiple roles, meaning that they were either midwives, nurses, or clinicians, and they also had an administrative component to their roles. And they served all HUCs that came to them. We can briefly go over the 11 care experience themes that emerged. For each care experience theme, we have the number of quotations and their distribution across users. The arrows denote the proportion of quotes that were positive, that's in green, and negative in red. To start with, participants' autonomy referred to their sense of control during their maternal care experience, such as the ability to practice rituals, having their choice of music, fragrances, or family members, and adjusting temperature and lighting as they needed. Social support for birthing persons included the support from support persons of their choice, family members and friends, and all the actions that they did to support the birthing person, such as rubbing their feet or back, or just be present in the room in general. It also included elements that helped SPs fulfill their roles in the maternal care experiences, such as spaces for support persons to rest, food and drink accommodations, etc. Comfort referred to features or aspects of the maternal care experience that provided physical, psychological, and emotional comfort. Proximity and access highlighted the physical distance and the ability to access the FSBC and community resources, such as public transportation, and features within the FSBC, such as spaces for walking, the proximity of the bathroom, other elements of the birthroom, etc. Positive distraction referred to elements such as artwork, music, fragrances, images, videos, nature views, plants that helped divert birthing persons and support persons from the stresses of labor and childbirth and induced positive emotions. Spatial perception highlighted the participants' perceptions of spaciousness, openness, and connectedness within the space. Flexibility and adaptability focused on the ability to adapt the space to different uses or preferences of users during the maternal care experience. Safety included physical safety, such as the provision of addressing complications during labor, and psychological safety within the setting, such as feelings of being safe and secure and not being afraid. Inclusivity highlighted perceptions of feeling welcome and included, irrespective of the user's race, ethnicity, culture, or socioeconomic background. Privacy highlighted participants' notions of modesty and preferences for privacy during labor and childbirth, such as the presence of male clothing and body covering, etc. Other themes included aspects of familiarity and visibility during the maternal care experience. In general, most of the participants perceived the maternal care experiences positively, and those of autonomy and social support were most frequently discussed. This graph shows the connections between the care experience themes and the physical environment at the community, facility, and room level. Community level elements were those elements that were outside the FSBC premises, but then talked about the connections of the facility to the community in general. Facility level elements were those elements that were within the FSBC premises, but outside the birth room, and the room level ones were the physical environments or elements that were within the birth room at the FSBC. We use this structure to analyze our case studies in the next phase. So, in the next part, we explored how the physical environment of freestanding birth centers led by midwives from HUCs helped them provide culturally sensitive maternal care to birthing persons from their communities. We used a mixed method case study approach for this study. We recruited 4 FSBCs led by midwives from HUCs that served HUCs in southern, southeastern, western, and northwestern United States. Data collection was done in 2 stages. In stage 1, we visited each FSBC for a week, during which we prepared architectural layouts, conducted a spatial and environmental assessment, and conducted field observations to understand space utilization and user flow. After the visit, we requested de-identified patient records from the FSBC to get a sense of the patient demographics and retrieved archival data about the city and neighborhood demographics and any grade literature about the facility. In stage 2, we recruited FSBC staff members to fill out a short survey capturing the demographics, experience, cultural competence assessment using an existing tool, the perceptions of the physical environment and for which they received an incentive. In the survey, we requested their participation for a follow-up interview, which we spoke about in part 3. We analyzed codes describing their workflow and the communities served in this part. We triangulated and synthesized all the data from these sources in an Excel spreadsheet and analyzed how the elements of these FSBC physical environments helped support our previously derived care experience themes. We can briefly go over each FSBC. FSBC 1 is located in a mid-sized city with a population of 122,000 in 2022 in southern United States, where 33% of the population are from HUCs. This is the only HUC-owned facility in the city and adjoining areas and primarily serves birthing persons from Black or African American and Hispanic or Latinx communities in the area. The FSBC was established in 2022 to provide respectful, compassionate care within the community. It occupies a renovated house and has 2 midwives and an office manager. It has 2 birth rooms and a dedicated consultation space with a waiting area in the middle. During consultations, the birth rooms and the consultation spaces were used to meet with birthing persons and their families. During birth, however, the waiting areas were used for family spaces, while consultation room was used as a staff space. FSBC 2 is located in a small city with a population of 71,000 in 2022 in southeastern United States, where 34% of the population are from HUCs. This is the only HUC-owned facility in the city and adjoining areas, and primarily serves birthing persons from Black or African American, Asian, American Indian or Alaskan Natives, and Hispanic or Latinx communities in the city and adjoining cities and states. The FSBC was established in 2021 to provide a safe and healthy space for respectful care for birthing persons in the community. This two-storied FSBC was previously a birth center that the midwife acquired and renovated based on their experiences and needs. It has 4 care providers, including midwives, doulas, nurses, and an administrative assistant. The FSBC has 2 birth rooms, 2 dedicated consultation spaces, and a spa room for birthing persons. It also has a dedicated family room, a kids' play area, and a shared pantry and dining on the lower floor. The upper floor mainly has a community space with a kitchen where new parents may meet every month, and a staff respite space for those who stay later in the day. They use the birth rooms and consultation rooms and family spaces for consultation so the birthing families could familiarize themselves with the space. During birth, public and community and family spaces were used for birthing families, with 1 prenatal room used as staff spaces. FSBC 3 is located in a large urban area with a population close to 3.9 million in 2022 in western United States, where approximately 70% of the population are from HUCs. This is one of the 2 HUC-owned FSBCs in the state and primarily serves birthing persons from Black or African American, Asian, American Indian or Alaskan natives, and Hispanic or Latinx communities, mixed race communities, and others in the city and the adjoining areas. The FSBC was established in 2020 in response to prevalent maternal health disparities and violence against HUCs and aimed to provide a warm, welcoming, and comfortable space for HUCs. The FSBC occupies 3 bays in a historical commercial space and was renovated by midwives and community members based on their experiences and needs. It has 4 midwives who also fulfill various administrative roles. The FSBC has 2 birth units with a birth room and ancillary space. Additionally, it has a living space, a large community space, a private outdoor garden with culturally relevant herbs and plants, and a covered space for birthing persons, families, and community members to use on good days. Consultations are primarily conducted in the living spaces or birthing units, with ancillary spaces being used by staff members. During perinatal care, the 2 bays act as individual birthing units with a birth room and ancillary space for birthing persons and family members. Unoccupied birthing units and central bays were used as staff spaces. FSBC 4 is located in a mid-sized city with a population of 105,000 in 2022 in northwestern United States, where close to 60% of the population are from HUCs. It also serves one of the most diverse communities in an adjoining larger city. This is the only HUC-owned FSBC in the area and primarily serves birthing persons from Black or African American and Native Hawaiian and other Pacific Islander communities in the city and adjoining cities. The FSBC is a non-profit entity and was established in 2018 in response to the prevalent maternal health disparities in the community and aims to provide an accessible, affordable, compassionate, collaborative care that is tailored to HUC's needs. The FSBC occupies 4 bays on the upper level of a commercial building. It was previously a boutique birth center that was acquired by the organization to provide care for the community while they constructed the other birthing center within the community in a larger city. It has 3 midwives that fulfill various administrative duties as well. FSBC 3 has 3 birth rooms and 2 consultation spaces. It also has a large waiting area and a dedicated equipment storage space and staff workspaces and pantry. They use the consultation spaces and birth rooms for prenatal and postpartum visits, so the birthing families could select their birth rooms and familiarize themselves with the room during prenatal care. Perinatal care was primarily provided within the birth rooms, and the waiting and public spaces were used by family members. The case study analysis focused on how the FSBC physical environment supported previously identified care experience themes. The table shows the care experience themes at different spatial levels addressed at various FSBCs. In the interest of time, we will only be discussing the 5 most prominent care experience themes. In terms of the birthing person's autonomy, at the community level, all FSBCs provided additional birthing options within the community that was accessible by private and public transportation. At the facility level, some facilities transformed the whole facility as a birthing space, especially when they had only one birth. In such FSBCs, open layouts with fewer corridors, such as in FSBC 1 and 3, encouraged fluid movement between various spaces, All FSBCs had a pantry and refrigerator for birthing families to bring, store, and reheat culturally relevant food. However, FSBC 2 and 3 provided a full kitchen for families to prepare the desired food while the BP was in labor. At all FSBCs, their birthing rooms had different spatial layouts, ambience, and decor to provide greater choice for birthing persons. Most birthing rooms had areas larger than those in the guidelines, that is, 120 square feet, to encourage movement within the space, and birthing persons were not restricted to the birth room and could move throughout the FSBC as they desired. In terms of environments for social support, at the facility level, waiting areas in FSBC 1 and 4 were used as family spaces. Alternatively, FSBC 2 had a dedicated space for family members and older children that was very helpful when they provided consultations and perinatal care simultaneously. All FSBCs had seating for support persons within the room. FSBC 1 and 2 had one larger birth room that accommodated more support persons if the birthing person desired that. Alternatively, birthing units in FSBC 3 had ancillary spaces for family members that could be integrated within the birthing space or kept separately as they desired. In terms of environments for comfort, at the facility level, all spaces within FSBCs 1, 2, and 3 had a deinstitutional decor, as these spaces were visible to birthing persons and family members. On the contrary, only spaces used by birthing persons and families, such as public spaces and care spaces in FSBC 4, had a deinstitutional decor. At FSBC 3, staff members highlighted the role of familiar environments for birthing persons and their families to feel comfortable. Within their community, FSBC 2 was known as the midwife's house, as the spaces within the FSBC resembled those that one might see in their own house. Staff members felt that this approach made the community members feel more comfortable while seeking care at the FSBC. At all FSBCs, the room decor resembled the overall aesthetics and decor of the FSBCs. The furnishings and finishes within the room had a textural variety with a combination of soft, yielding, and hard surfaces for comfort during various stages of labor. Also, they had all birth rooms had a birthing bath, a bed, an ensuite toilet, and sufficient space on the floor for birthing persons to change positions and locations to improve their comfort during labor. All birth rooms had multiple lighting options with dimmers so that the birthing persons and support persons could change the lighting as they needed throughout labor. They had similar options for temperature as well that could be adjusted as needed. In terms of proximity and access, at the community level, all 4 FSBCs provide maternal care to HUCs from 37 to 66 zip code regions within and outside their cities, sometimes outside their state as well. Some birthing persons travel long distances, up to 300 miles, to receive their desired care with the providers from HUCs. To ease access for birthing persons and their families, FSBCs were located closer to highways and bus stops. But staff members said that the distance, city scale, and traffic conditions affected the time taken to reach the FSBC during labor. Though they discussed these concerns with their birthing persons, they mentioned that birthing persons from HUCs prefer to seek maternal care at FSBCs led by midwives from the community in an attempt to regain autonomy over their childbirth. Overall, the FSBC size and scale made all spaces accessible within the FSBC. In some cases where they had long corridors and separate bays without internal connections, led to the perception of longer travel distances between these spaces, but in other cases where they had a more open layout, central waiting spaces could be used to access all the adjoining spaces, making it easier to walk through. The proximity of the birth room to the FSBC entrance was also discussed, as it affected the timely access for birthing persons arriving in advanced labor. In most FSBCs, they had at least one birth room that was closer to the entrance in such situations. However, in FSBC 1, they had an alternate entrance to the birth rooms from the entrance patio or the entrance lobby that could be opened up for women arriving in advanced labor. In terms of positive distraction, most FSBC spaces had windows for natural light. However, these windows did not always overlook landscaped gardens or elements of nature due to their location and scale. Elements of positive distraction within the FSBC spaces were more significant in these cases. All FSBCs incorporated elements of positive distraction such as elements of nature, artwork, murals, and motivational quotes. FSBC 3 had indoor plants of different varieties in most spaces within the FSBC. They also had a private outdoor garden for birthing persons and families to walk through. This garden had murals, spaces to sit, and pathways to walk through while engaging with the plants during different points of time. In FSBC 2, they had a spa room for positive distraction for people to relax during labor or postpartum. In birth rooms at all FSBCs, they also incorporated elements of nature through artwork, artifacts, and indoor plants. Due to the scale and size, most windows within the birth rooms most windows within the birth rooms overlook public spaces and were primarily used for natural light. Only in FSBC 3 and FSBC 4, some of the birth room windows overlooked greenscapes. That could be the indoor garden in case of FSBC 3 and trees at a distance in case of FSBC 4. Another highlight was that most of the FSBC spaces had motivational quotes integrated within their artwork. And the staff said that birthing persons really appreciated these supportive and encouraging words during labor. They also gave birthing persons the option to bring pictures, affirmation cards, religious or cultural items, and their music, flowers, or fragrances to personalize these elements of positive distraction within the birth room. We conducted a similar analysis for all care experience themes and found that the FSBC features supported multiple care experience themes. At the community level, having an FSBC improved birthing options within the community. Birthing persons travel long distances to receive the desired care, some people traveling longer distance in time than others. At the facility level, FSBCs had a different approach to care and care support. Some were different approaches to care and care support, some that were more fluid than others. All FSBCs had a deinstitutional, uncluttered, and clean environment and provided opportunities for the birthing persons to familiarize themselves during prenatal care. FSBCs had different strategies to accommodate family members and support persons within the space. At the room level, all FSBCs provided opportunities for control and adapt room temperature, lighting, sound, smells, and textures. Care and care support features within the room centered around the birthing persons and the family's needs and desires. Staff and staff support features within the room blended in to provide access when needed without taking away from the overall aesthetic of the room. Overall, we realized that the FSBCs led by midwives from HUCs were few. Therefore, they served HUCs from their city and adjoining areas and states. A combination of organization, spatial, and environmental design strategies helped support culturally sensitive care. Again, the physical environment across all spatial levels contributed to the birthing staff's ability to provide culturally sensitive care, and many physical environment features supported multiple care experiences. Additionally, we learned that maternal care at FSBCs was centered around birthing persons and their families. However, freestanding birth centers were short-staffed, low-resource settings, often designed by midwives based on their experience. That brought us to our overall purpose. Through this study, we wanted to create a resource for midwives and design teams to help them create appropriate maternal care spaces that reflect the needs of HUCs, improving their maternal care experiences and outcomes. That led us to developing evidence-based design guidelines supporting culturally sensitive maternal care for HUCs. The objective was achieved by synthesizing findings from literature reviews, surveys, interviews, and case study analysis. The main objective of these guidelines is to improve culturally sensitive maternal care experiences and outcomes for birthing persons from HUCs. In doing so, we can improve responsiveness to HUC beliefs and circumstances, provider birthing person engagement and relationship, community support, care participation and adherence, and likelihood of a physiological birth. We developed 13 guidelines based on culturally sensitive maternal care experience themes, and they're supported by evidence from different parts of the study. We can briefly go over these guidelines. The first one focuses on improving the birthing person's sense of control, allowing them to fulfill their preferences and desires during the maternal care experience. Opportunities for desired support persons and family members and friends to be present and involved. Improve physical, psychological, and emotional comfort. Proximity and access to care settings, important features and resources. Incorporate culturally significant elements of positive distraction. Understand culturally relevant maternal care needs and provide services, spaces, and support systems to ensure overall health and well-being during care processes. Help providers be flexible and tailor their processes, policies, and physical spaces to accommodate the birthing person's maternal care needs and preferences. Not only improve physical safety by understanding medical and physical risks, but also provide a space for birthing persons to feel secure, respected, and supported to discuss their preferences and needs with care providers. Creating an inclusive space where people from HUCs feel welcome, represented regardless of their race, ethnicity, culture, and socioeconomic background. Provide spaces that can accommodate varied preferences for modesty and privacy. create processes and spaces that allow people from HUCs to familiarize themselves and improve their knowledge of the space and setting during prenatal care. Be mindful about preserving the institutional familiar aesthetic and decor within birthing spaces while supporting staff members and providing necessary care and respond to emergent situations. Improving visibility between the birthing persons, support persons, and staff members, and elements of social and spiritual support from different parts of the birthing room and the FSBC as a whole. For each guideline, we have a definition articulating what the guideline means, a rationale showing why it is important for maternal care spaces for HUCs based on literature and our study findings, some suggestions and recommendations for how we might achieve this guideline at various spatial levels of the physical environment, and some examples of how some of our case study sites achieved them. Many times, some recommendations and implementation strategies address multiple guidelines, so we have summarized these guidelines by spatial level to highlight key recommendations. For example, at the community level, locating maternal care facilities to provide a greater choice for birthing settings can improve autonomy, comfort, proximity, and access, provide opportunities for culturally relevant care while improving physical, psychological, and cultural safety. We have similar summaries for the facility and room level recommendations as well. These guidelines and recommendations are not intended to replace existing guidelines, but help us think of and address aspects of cultural sensitivity, competence, and responsiveness within them. Most importantly, they highlight how we might begin to conceptualize maternal care spaces that allow us to respect families from HUCs, meet them where they are at, and be supportive of their journey. Like this midwife says, this is their whole lives. They will live their whole lives with each other and their baby. We are there for one moment, and we should never take that away from them, because you get only one time to do this, to birth this baby. Like every study, our study has some limitations as well. Our literature review was not a systematic literature review, and we must have missed articles because of our approach. We experienced many recruitment challenges with our surveys and interviews. Since HUCs are very diverse, we are limited by a pool of participants, most of whom identified as Black or African American. There are very few FSBCs led by midwives from HUCs. That limited our pool of case studies. Also, the uncertainties related to childbirth limited our ability to observe those during our week-long FSBC visits. Lastly, our guidelines are mainly derived from FSBCs, limiting their generalizability to high acuity maternal care settings. However, in terms of design implications, the study begins to show how the physical environment influences culturally sensitive care experience for HUCs, provides guidelines and recommendations for how they may be improved. It also shows interconnections between different spatial levels of the physical environment and how that might contribute to the overall experience of maternal care, highlighting the need for a more holistic approach. Additionally, the study highlights the role of physical environments as the context for maternal care interactions, allowing it to reflect the healthcare organization's values and bridging those with HUC cultural expectations. As for next steps, our study primarily focused on the physical environment within this broader framework and how that contributed to care experience. The study highlighted the mediating role of the physical environment to bridge HUC expectations and FSBC organizational values, exploring those aspects that can improve our understanding of the role of the physical environment. This is just a starting point, and HUCs are very diverse, so we will need more studies like this with culturally diverse HUCs for generalizability and creating more comprehensive guidelines and recommendations. Another thing is that we were unable to validate the guidelines so far, and that's something that we're trying to do right now. So if you would like to know more about the guidelines and help us validate them, please scan this QR code and contribute to our study. Before concluding, I would like to thank all the people who made this study possible, including my advisors, friends, peers, family, and the organizations that supported this study. None of this would be possible without them. Again, thank you all for your time. Please reach out to me if you have any questions, and please do help us validate the guidelines and contribute. Thank you again.